1.1 What is CPR? According to World Health Organization, WHO, heart diseases are the most common cause of death worldwide. The basic purpose of CPR is to help in proper handling of these life-threatening cardiac events and other emergency fatal incidents. Cardiopulmonary resuscitation, CPR, is an emergency life-saving procedure which may be performed when a person stops breathing or the heart stops beating, a person in sudden cardiac arrest. CPR may help the flow of oxygen and blood to the brain and other vital organs while the medical staff try to get the heart to beat normally again. 6 major steps of BLS. Basic life support. BLS, basic life support, is the initial care provided by healthcare providers, public safety professionals or other related persons to anyone who is experiencing obstructed airway, cardiac distress or respiratory distress. BLS enhances the chances of survival of a person until advanced care becomes available. There are 6 major key steps of BLS which are: 1. Quickly starting the chain of survival steps as soon as possible. 2. To deliver high-quality chest compressions for maintenance of oxygen circulation towards the brain and other vital organs. 3. Proper handling of automated external defibrillator. 4. Providing rescue breathing. 5. Understanding how to work as a part of rescue team. 6. Adequate knowledge of how to treat choking. Initiating the chain of survival. Quick initiation for chain of survival steps has been shown increased chances of survival for a victim of cardiac arrest. According to American Heart Association, AHA, there are 5 main steps for chain of survival which should be taken as soon as possible. These steps are: 1. Immediate recognition of the symptoms and activation of emergency response team. 2. Early CPR with main focus on chest compression. 3. Rapid defibrillation with AD. 4. Advanced life support. 5. Integration of post-cardiac arrest care. 2015 Basic Life Support Guidelines. With respect to CPR in 2010, the American Heart Association, AHA, published modified BLS guidelines. The International Liaison Committee on Resuscitation, ILCR, released their 2015 guidelines for cardiopulmonary resuscitation, CPR, and described that high-quality CPR in patients may significantly increase survival rates after their hospital discharge. The ILCR's modified 2015 guidelines confirmed many of the recommendations of 2010 guidelines and demonstrated that high-quality chest compressions are the most beneficial tools to improve resuscitation outcomes. Below is the brief summary of the changes made to 2015 guidelines for CPR. Previously, the CPR was based on ABC, airway, breathing, compressions, protocol. Modern guidelines recommend to perform the CPR into 3 steps protocol, i.e. C, CAB, and ABC. 1. C compressions only. 2. CAB compressions, airway, breathing. 3. ABC airway, breathing, compression/circulation. Look, listen, and feel (LLF) approach to assess breathing is no longer recommended. It is advised to initiate CPR if a. the victim is not breathing or only gasping for breath, b. has no prominent pulse or you are unsure to fin the pulse, c. the victim is unresponsive. The goal for skipping initial assessment of respirations is early delivery of chest compressions for cardiac arrest victims. 2017 updates suggest that untrained lay rescuers should only provide chest compression, hands only, for victims of cardiac arrest. High-quality CPR is the major key and should be performed as quickly as possible through following modified guidelines: 1. Maintain compression rate of at least 100 to 120 per minute for all persons with a depth of 2 to 2.4 inches for adults and children and about 1.5 inches for infants. 2. Allow complete chest recoiling after each compression. 3. Always continue to perform CPR without interruptions, except to use an AD or to change rescuer positions. 4. Do not overventilate and try to perform CPR as a team when possible. Cricoid pressure is no longer recommended and it is not routinely performed. Pulse assessment should be shorter and it is recommended to feel a pulse for at least 5 seconds but no more than 10 seconds. If a pulse is not palpable or if you are unsure for a pulse, then immediately start chest compressions. Even trained clinicians cannot always be sure to palpate the pulse in collapsing victims. For infants, less than 12 months, use a manual defibrillator if available. However, if it is not available, then use automated external defibrillator, AED, with pediatric dose attenuator. If an AED with pediatric dose attenuator is also not available, move towards the use of an adult AED, even for an infant. 1.2 History of CPR. History of immediate resuscitation attempts to reverse sudden death is as old as human history. However, until the 19th century, routine resuscitation to manage cardiac emergencies was not considered as a feasible technique. Modern cardiopulmonary resuscitation, CPR, was developed during the last few decades of the 20th century. Different timelines for development of modern CPR are given as 1732 to 1740. In 1732, a local surgeon from Scotland, Dr. William Tossack, used mouth-to-mouth breaths to stabilize a suffocated coal miner. It was later documented and thought to be the first documented clinical description of mouth-to-mouth resuscitation. 1774, William Hawes and Thomas Cogan, London-based physicians, established Society for the Recovery of Persons Apparently Drowned, SRAPAD, which later became the Royal Human Society to assist drowning victims of sudden and unexpected death. 1800, in 1800, Hall and Sylvester formulated a method of artificial respiration which was used until 20th century. 1891, Dr. Friedrich Maas performed first documented chest compressions in humans. Dr. Friedrich, a German surgeon, after using external compression, reactivated the heartbeat of 2 young humans, became the first to advocate chest compressions. 1903, in Cleveland, Dr. George Cryle reported first documented successful external chest compression in human resuscitation. 1904, Dr. George Cryle reported first successful closed chest cardiac massage in humans. 1924, the American Heart Association, AHA, was established by 6 cardiologists in Chicago as a professional society for physicians. 1933, Johns Hopkins University's researchers accidentally rediscovered external compressions while performing experiments on a dog's sternum. 1947, cardiothoracic surgeon, Dr. Claude Beck performed first successful documented defibrillation through electrical defibrillator. 1956, Dr. James Elam and Dr. Peter proved that mouth-to-mouth resuscitation is an effective life-saving method through a series of experiments. 1960, CPR was developed in 1960 and AHA started a program with physicians for closed-chest cardiac resuscitation. 1963, AHA's CPR committee was established by Dr. Leonard Shirless and AHA formally endorsed CPR in the same year. 1966, the National Research Council of the National Academy of Science established standards for modern CPR. 1972, Dr. Leonard Cobb launched world's first mass citizen training in CPR. 1975, first Advanced Cardiovascular Life Support, ACLS, textbook was published by AHA. 2005, AHA published 2005 guidelines for CPR and recommended a new compression to breathing ratio of 30:2 along with modifications to AED usage. 2008, AHA released new recommendations and demonstrated that bystanders can skip mouth-to-mouth ventilation and can use compressions only in emergency situations. 2010, AHA published 2010 guidelines for CPR. 2015, AHA published 2015 guidelines with various modifications in 2010 guidelines. 2017, AHA continued the comprehensive research and released 2017 focused updates for 2015 guidelines. 1.3 Chest compression, an appropriate way to do compressions. As discussed, American Heart Association, AHA, recommended the 3 protocols of CPR, depending upon specific circumstances and training. These are, 1. C compressions, hands only, 2. Cab compression, airway, breathing, trained rescuer, 3. ABC airway, breathing, compressions, trained rescuer. Compressions, hands only, is the most effective tool for CPR in adults experiencing cardiac arrest, but it is not advised in children and infants, who suffer from respiratory arrest more as compared to cardiac arrest, and need oxygenation and cleared airway along with compressions. Recent studies have shown that compressions, hands only, alone for infants and children are no more effective without airway clearance and oxygenation. Compressions, hands only, as bystanders are reluctant for mouth-to-mouth breathing and are often not familiar with CAB or ABC protocols of CPR, the compressions-only/hands-only procedure is the easiest to perform even without proper training. When laypersons encounter anyone in cardiac arrest as evidenced by no breathing, lack of responsiveness or grasping only, they should immediately initiate the chest compressions. Laypersons or bystanders should evaluate the victim on the basis of responsiveness and breathing only because most of them are not trained enough to palpate pulses. They may waste valuable time to palpate a pulse or mistakenly feel their own pulse. However, Healthcare professionals should evaluate the victim based on palpation of a pulse along with breathing and responsiveness. Remember, do not spend more than 10 seconds to feel a pulse. The ideal site to assess a pulse is carotid pulse in the neck area. If there is no pulse along with lack of responsiveness and breathing, then compressions, hands only, should be an ideal initial protocol to follow. Before initiating compressions, the victim should be placed at his/her back on any hard surface, floor. Remember that compressions must be over the sternum and it should be avoided the xiphoid process that can break easily during compressions. The most convenient method to find the correct hand position is to move 2 fingers along the ribs towards the central chest, place 2 fingers over the xiphoid process and place the palm of the other hand directly above the fingers on the sternum. The hand position should be between the nipples and less enlarged or / pendulous breasts. Once the correct position for hand placement found, the other hand should be placed on top of the first, fingers linked, and elbows locked, to finally begin the compressions. Compressions must be done in a rocking movement, and use the whole body to apply pressure instead of just the arms. The arms should remain locked rather than their flexion during compressions. If you attempt to use only the force of the arms during compressions, the adequate depth of compression can never be achieved. The compressions rate should be around 100 to 120 per minute with target depth of 2 to 2.4 inches. The chest should recoil between each compression for proper refilling of the heart, however the rescuer should maintain the same hand position in contact with the chest as lifting the hand can result in misplaced position around different spots. The common complication of chest compressions, especially in older adults, is the fracture of ribs during exerted pressure. As the ribs fracture is not life-threatening but the cardiac arrest is fatal, so continue to provide the compressions without any discontinuity. Fractures usually occur when the rescuer does not maintain the proper hand's position over the sternum. It is estimated over 1/3 victims undergoing CPR experiencing fractures. The rescuer should continue the compressions at same rate until the victim starts to breathe independently along with prominent pulse and responsiveness. Once the victim is stable or medical facility becomes available, the rescuer may discontinue the compressions. 1.4 Why do chest compressions? Physiology and benefits of chest compressions. A physiology of chest compressions. According to the Center for Disease Control, CDC, heart diseases are leading cause of deaths in the United States, responsible for over 600,000 deaths every year. Heart pumps deoxygenated blood to the lungs, where oxygen is captured into the blood from lungs and carbon dioxide from the blood is released into the lungs. The oxygenated blood then returns to the heart for pumping out throughout the body including the brain and other vital organs. When the heart stops working, blood flow towards the brain and other vital organs also stops, which results the victim to become unconscious immediately. Without adequate blood flow, heart, brain and other vital organs may be damaged due to lack of oxygen supply. The major function of chest compression is to prevent or slow the damage until the advanced life support becomes available. During compressions, oxygenated blood is pushed out from the left side of the heart to supply throughout the body including the brain and other vital organs. At the same time, deoxygenated blood is squeezed to the lungs from right side of the heart, where oxygen is transported into the blood from lungs. After compression, when the pressure on the chest is released, deoxygenated blood flows from the body towards the right side of the heart and oxygenated blood from the lungs returns to the left side of the heart. Overall physiology of chest compressions can be summarized into 2 phases. Phase 1, applying pressure during compressions, oxygenated blood from the left side of the heart throughout the body, deoxygenated blood from the right side of the heart, lungs, oxygenation of the blood, return oxygenated blood to the left side of the heart. Phase 2, releasing the pressure on the chest, deoxygenated blood from the body, right side of the heart, lungs, oxygenation of the blood, oxygenated blood returns in the left side of the heart. As discussed earlier, compressions should be at a rate of 100 to 120 per minute with the target depth of 2 to 2.4 inches. When there are too fast compressions, above 120 per minute, heart does not get sufficient time to refill with the blood. When there are too slow compressions, less than 100 per minute, there would be less supply of oxygen for the tissues. Similarly, when the compressions are not deep enough, less than 2 inches, the amount of the blood pushed out from the heart may be not sufficient to meet oxygen demands of the tissues. Therefore, compressions must not be too fast, not too slow, and should be deep enough to maintain an adequate supply of oxygen for the brain, heart, and other vital organs of the body. Benefits of CPR. CPR may save lives, especially for young and healthy persons, right after their heart stops. In some cases, CPR returns the person to same healthy condition as he or she was in before the heart stopped. It is more likely when a person does not has any serious health issue, along with if CPR started immediately after the heart stopped working. Chances of survival mostly depend upon health condition, age of the victim, and how quickly CPR initiated. We can summarize the benefits of CPR as 1. Life-saving procedure. CPR is an ideal initial procedure to save the life of a person who stops breathing or his/her stops beating. Quick application of CPR supports the victim to start to breathe and enables the successful return of spontaneous circulation, ROSC. 2. Increasing survival rate. CPR can take the patient back to normal condition. Recent studies have shown that an early application of CPR may increase 40% chances of survival. 3. Minimize the damage. CPR may return the spontaneous circulation to maintain an adequate supply of oxygen to the brain and other vital organs, thus it can minimize the damage of these vital organs significantly. 4. Preparation for treatment. Remember that CPR does not cure any cause of the heart failure. However, it enables the victim to prepare until the advanced life support becomes available. Thus, it provides an opportunity to the medical team to handle the cardiac emergencies effectively. Complications of CPR. Major complications of CPR include 1. Rib fractures, 2. Lungs injuries such as lung contusion and pneumothorax, 3. Abdominal organs injuries such as splenic, gastric, and hepatic injuries, 4. Internal bleeding from fractured ribs, 5. Forced supply of oxygen may lead to brain damage and stroke, 6. Resuscitation through mouth-to-mouth may cause spread of infections.